Sleep disorder is very common among the older population. It's something that geriatricians are always being asked and patients often struggle with. Various reasons for changes in the sleep pattern, sleep architecture is changing as we age. It's more difficult to fall into that deeper sleep. There are not that many wonderful medications for insomnia, and so often we encourage sleep hygiene as the first line, so non-pharmacological interventions, trying to set up the sleeping space as just the sleeping space, increasing daytime activity, and so that the body feels more tired, more stressed, more worked out, so that by the time evening comes, then it is the time for sleeping, kind of training the body to wake up at the same time and try to go to sleep at the same time, and reserving the bed for sleeping. In addition to improving the sleep hygiene around the insomnia aspect, also trying to reduce light at nighttime, reduce television, blue light. There are various ways that geriatricians can teach families and patients how to make their bodies more sleepy when nighttime comes. Urinary incontinence is a real struggle, a real challenge for many of our patients. Sometimes the factors are not necessarily having to do with the bladder itself or the urinary system. It may have to do with their mobility or their ability to actually get to the toilet. It may have to do with remembering or their cognition as well, or their ability to communicate that they do need assistance with getting there. There's many reasons for incontinence of the bladder or the bowel. It's a very important topic that perhaps the geriatricians may bring up, as it could be a sensitive question for our patients. As we get older, pain is a common concern, so it's important for geriatricians to really identify where the source of the pain is coming from and what type of pain it is. Is it neurologic? Is it musculoskeletal? What kind of neuropathic is it? What kind of pain are we working with, and what is the best non-pharmacologic and pharmacologic intervention? If we can go without the medication, that would be best. If there can be physical therapy or some other massage or other modality, we'll work with that. If we need to move on to medications, then we'll determine based on the patient's physiologic function, their comorbidities, their renal function, their liver function, what is the best appropriate medication and how should it be dosed? Keeping in mind that the consequences of, for example, in opioid medication, you may also need to watch for other side effects such as constipation or other bowel dysfunctions.